Okay. Good afternoon, everyone. I'm
Good
extremely
afternoon.
delighted to have such an eminent faculty with us today, Dr. Mohan Bhuvaneswaran. He is an accredited member of American Academy of Cosmetic Dentistry. As far as I know, there are only 2 such members all over India. I welcome you, sir, to our webinar. I also welcome all our members and other national and international participants. I would like to thank Dr. Mohammed, who is our own member, for making this webinar possible. Now I invite Dr. Samina Mohammed to introduce the faculty. Thank you.
Good morning, sir.
Morning. Good afternoon.
Good afternoon. And good afternoon to all the colleagues who have joined in for the webinar. Hope you're all doing good and staying safe and enjoying your lockdown period. And of course, the Ramzan too. I'm so proud to introduce our own Mohan, sir. Sir, we are blessed to be your students. And now to the introduction of the sir. Dr. Mohan Bhuvaneswaran has completed his postgraduate. Okay, sir. Sir has completed his PG in Sir has completed his PG in conservative dentistry in 2001 from the Government Dental College in MGR Medical University, Chennai. He started his teaching in a dental school in 2001 and was the HOD of the conservative in SRM University and associated dean. Now he is into his full-time practice and owns a private clinic in Chennai, which is a multi-specialty hospital. He is a celebrity dentist who's been giving his talks in Malaysia, Ramchandra University, Chennai, and he's also a professor of MAHA University, Malaysia. He's an accredited member of AACD in the year 2014, and he's undergone extensive training in composites and ceramics in Switzerland and USA. He's here today to share us his knowledge, and he's also been awarded the Lifestyle Award in India, Best Affiliate Leader of AACD for the year 2017, Famden Superstar Award 2018, and he's the brand educator for American Academy of Cosmetic Dentistry and Indian Association of Conservative Dentistry. He has his hobby as photography and married to Rupa ma'am. He's blessed with 2 children. Sahitya, his daughter, is 12 years old, and Talin is 5th class, sir.
Hello.
Sir.
Yeah. My daughter is in 12th standard. Finished at 12th standard.
Finished 12th standard, and son is doing his 5th standard. And now I request Mohan sir to take over the session. Thank you, sir. Thank you for accepting our request very much.
Thank you so much. I would like to before I start, I think the admin has to give me permission to move further because my screen is locked.
Okay, sir. Please request.
Yeah. My screen is not moving.
What permission you want, sir?
Yeah. It's coming. It's coming. No problem. Sorry. Yeah. No, generally the admin blocks the.
Okay.
It gets difficult. Okay, fine. Thank you. So a very good afternoon to all of you. And I would like to thank the Kondati branch IDA for giving me this valuable opportunity of sharing little about the ceramic laminates, what I know in this pre-lunch session. So I hope all of you are really, really active. And I would also special mention about my 2 great students, Dr. Mohammed and his wife, for seriously, because of them only I'm right in front of you. Thanks to both of them and all the members of office bearers of the IDA branch and all the participants who are listening to me during this period. Of course, all of us are going through this unprecedented time, so we are trying to make use best time that is given to us during, so we don't know what's going to be normal after this, so let's try to utilize this time. So today the topic is requested, it's on ceramic laminates. I'm going to talk for almost an hour now, so because it's also lunch time, so I will not extend too much. So for almost 1 hour, I'll be talking about the various aspects of ceramic laminates. I understand there must be a lot of beginners also, so I've considered a wider range of participants listening to me. So accordingly, I've put my presentation for all levels so that everybody has some take-home message for them. And after this, probably I will spend more time on answering your questions. So please feel free to answer the ask any number of questions. I will be able to give my best to that. So with that small note, we'll start with laminates. This is what everybody's looking into today. They want to get a beautiful smile done today. It's all smile makeovers with everybody's asking for smile makeovers. So earlier, probably patient was coming to our clinics. Probably we don't know what's going to be there tomorrow. At least till yesterday, till before last month, we had patients coming and ask, doc, I don't like this. I don't like this. Can you do something about my front tooth? So one of the answer was a laminate. Right, one of the answer. It's not that always, it's a misconception. I want to very clearly tell that. Probably I'm going to show you some cases, going to discuss materials, going to discuss about cementation, about tooth preparation. It's not that just because I'm trained in laminates, I do laminates to every patient who enters my office. That's the wrong thing. I offer healthy smiles to my patient. We don't treat patients with bonding, extractions, ortho. We offer them happiness. We offer them hope. We give them self-confidence. That is what our office provides. It's not that I want to convert every case to a ceramic laminate. No, that is not the right treatment at all. And if you start working that way, so it will not work at all. So one of the mode of smile makeover, please understand, one of the mode of smile makeover is laminate. And we have composites and ceramics. And today we're going to discuss about ceramics. So what exactly do I mean by laminate is exactly what you're seeing. That's a definition. So it's a layer. See, anything can get laminated, right? Your desk right now, if you're putting your laptop, that also is laminated actually. So it is a covering which covers what is underneath. So you don't want to see what is underneath, so you cover it up, and that is laminate. And a dental laminate is one which covers up the tooth, which is probably discolored or malformed. That's all. So probably most of the time people ask me, what is a laminate? What is a veneer? We don't mind if you interchangeably use this terminology veneer and a laminate. Both mean the same to us. If you're very specific, and especially in prosthodontics, they ask this in the exam, laminate is when you don't have much of tooth preparation, then just one layer, then it's a laminate. If you do little tooth reduction and then put a ceramic portion, then that is called a veneer. But we are not bothered about the terminologies at all. What we are more bothered about is that how conservatively we do this procedure is what our bother. It's more a botheration. So coming on to the next question, what you knowing what is a laminate, the next question you would like to, what are the types of laminates? Probably when all of us did the undergraduation, we read that in Studio 1 that you have a small window type like here. Probably it comes and overlaps the incisal edge. It'll exactly stop at the incisal edge. It'll overlap the incisal edge. All those are observed today. Today, if you want to classify, there's a classification given by Galibrull. He in his textbook on ceramic laminates, porcelain laminate veneers is given this beautifully. Now always classification becomes only for writing in the exam. So I know that people don't want to by heart classification, because the minute I talk about definitions and classification, people always relate it to putting it on the paper. That I'm going to do it. But we need this for communication. So I will project cases so that it enters your mind. So type 1 is basically when teeth are resistant to bleaching. When they're discolored teeth and you want to do something, then it is a type 1. When it is malformed, it is type 2. When it is extensively malformed, then it becomes type 3. So I'm going to show you some cases. Now look at this case. When you look at this case, it is obviously a case of discoloration, which the patient is not liking the color of the tooth. So he or she wants to change the color of the tooth. Otherwise, the gingival health and the white foundation we call is perfect. Is absolutely perfect except for the discoloration. So the first option would be to do a bleaching procedure, because the procedures have to be as conservative as possible. But the sight of it makes it very clear that this tooth or this set of teeth is internally discolored. So if you want to do bleaching, probably it reduces the discoloration, but not to the extent what the patient is expecting. So all this should be in our mind. The end vision today, if I want to travel to Cochin, okay, that is my end vision. I decide. I don't blindly call I don't book a Uber and then sit down and ask him where to go wherever you want. I cannot do that. Okay, go to airport. Then I decide where I'm going to. Even before you reach airport, you already decided which flight you're going to take to Cochin. Yes, that is what is treatment planning. So I know my end vision knows that even if I do bleaching, I cannot come to the expectation of the patient. So I'm very clear in treatment planning. Though we are going to do veneers, I want to reduce. I'm going to discuss why I need this. So this becomes a type 1 case wherein it's discoloration and you're going to manage that. Now, when you look at this case, we know that the teeth are not in the right shape. You know the laterals are peg laterals and there is a diastema in between them and the inclinations are also outward. So I need to change the morphology. Of course, I'm happy with the pink. Pink is the gingival. The gingival aesthetics is beautiful, but only thing my white component is not very, very good. Even if I do ortho, I'm not going to get there. So this is an ideal case of a ceramic laminate. So case selection is very, very important. Now look at this. When you look at this, this is a proportion discrepancy, right? The proportion discrepancy is that look at the 4 incisors in the upper segment. They all look like centrals. You don't differentiate between if it's a central or a lateral. This is an ideal case for a ceramic laminate, wherein I need to convert my laterals to laterals and centrals to lateral, centrals to centrals. This is a classical example of type 2. This is again an invert smile line, which is again you're altering the morphology. So all these belongs to type 2. Look at this, extensive. So extensive is when you have such deformities, you have to extensively alter the morphology, then it becomes type 3. So easy to remember for communication if I'm doing a type 1 case, type 2 case and a type 3 case. So what does that communicate to the laboratory is the amount of ceramic consideration that has to be going into for the material selection. So that is what is very, very important. Again, I tell you right today, it's not single-handed dentistry. It's comprehensive dental care. That means I need to have a team with me. I need to involve everybody. Everybody speaking the same language and having one vision. So that is the key for today's dental practice. So now look at this. After probably the end of this lecture after 1 hour, the next thing is that you definitely, anybody's mentality is you want to try out. You want to try out ceramic laminates and change the smile, make the patient happy and see that he or she brings in more patients. That is what is everybody looking into if probably going into the training. Yeah, everybody's gone through that. And this, if you look in the eyes of doing a ceramic laminate, this can be the ideal case for ceramic laminate. Why? Because I just have to move the gingiva up with laser in tooth number 2-1 and then go ahead with laminates. It will look awesome. But is that what we are looking at? No. The end story of smile makers given by Peter Dawson in his textbook is a stable stomatognatic system. So I have to create a stable system. My joints and everything have to be stable in unison. So if I do this, okay, everything is going to be stable. Nothing is going to go wrong with my joint, but I have a risk factor. See, the risk factors should be kept minimal. The minute I grind, the biomechanical risk increases. So I don't want to unnecessarily grind my tooth structure. So what else is an option is a short-term orthodontics, even without involving the molar. So this is what is today everybody talks about. So short-term ortho, if you look at it, it already moves the teeth inside. It changes the position of the gingiva. I don't touch the gingiva. I don't touch the tooth structure. I finally finish with the case with a small diastema closure with composite resin. So how beautifully, minimally you do the dentistry is what is the key to the success. Now look at this case. I'm going to show you this case in case discussions. So this patient comes to us with the hanging deciduous tooth. She has come back and telling that if you touch it, it's going to fall. Don't touch. I want a replacement. Okay, you want a replacement. Putting a replacement there is spoiling a tooth. Always remember, you can put an extra canine. This all comes in smile designing. You can put an extra canine, but never an extra incisor or a lateral central or a lateral incisor. That will spoil the smile very badly. So here, I know what my orthodontist can do. So I advised her, do a short-term ortho, you'll get it. Definitely all these patients will tell, I will not. So that is the first temptation for us. Patient itself is told, don't want ortho, do some crown, do some braid, do some. So that is the temptation for all of us when you're looking into practice. If my mind is decided, this is what is right for the patient, if this is what is right for my sister or brother, that's all, it's decided. I'm not going to change for you. Get ortho done, nothing else. If you don't do ortho, I'm not going to do any treatment for you. At that point, patient realizes that this guy is talking some sense, and at one point they will accept, because I know long-term success. I'm not going to see this patient today, tomorrow, and that's all vanish. No, they're going to come to me. I want my patients to come to me even after 10 years, 15 years, 20 years. Anything happens, I want to come to me. So I need to have a strong relationship with my patients, not just mechanically doing. I'm not selling commodities here. I'm not selling clothes here. I'm not selling jewelry here. I'm a healthcare provider. I want my patients to come back to me with all due respect. So for that, I should be truthful to my patient, right? So look at this. After 4 months of ortho, this is where we are. Simple. Absolutely, I don't even have to put my aerator handpiece onto the patient's mouth. This is what is successful dentistry. Let's see this case a little later. Now, this patient again comes to me and asks, Doc, okay, let's not waste time. I'm in a big hurry. That's what everybody tells. I've come from Middle East. I just have 4 months, but please do 4 crowns for me. I do 4 crowns? Where do I do 4 crowns for you? Doc, somehow in school time, I didn't get ortho done. Now I want something to be done. Please do anything other than ortho. Doing 4 crowns is a crime. It's a real crime. So please, what do we do is that explain to the patient that get ortho done. Initial resistance will be there, but finally look at that. After 9 months, this is what we are. So it is important to practice responsible aesthetics with predictable success. So with that small introduction, we will go on to the presentation. The presentation would have 3 parts in it: the material science, the tooth preparation, and case discussions, of course, with a little bit of insight into cementation. Going on to material science, it's very, very important because people today are so much inclined towards zirconium. So I'm going to discuss what material. There's only one choice for us. So just forget it. What material is for you to understand the current generation of ceramics. I'm going to explain both. So all ceramic restorations, basically, why everybody likes that is that there are no dark lines at the gingival margin and it looks beautiful. No obstruction of light passing through the crown, so it increases the aesthetics. The gingival health is excellent, an excellent seal of the cavo surface mantle. This is why people don't prefer metal ceramics and do all ceramics. Needless to mention that laminates have to be only all ceramic, cannot be metal ceramic. Simple as that. So people come and ask, look at that, a badly done metal ceramic and then an all ceramic. Definitely there is a big improvement in the patient's smell. So this is why people talk about all ceramic. So when you come to classification of all ceramic, this is how we classify: glass-based ceramics and oxide-based ceramics. Obviously, all of us know that glass ceramics look really, really beautiful. When you talk about beauty, it's always a ceramic cup. It's never a stainless steel cup. That is why we don't prefer metal. So when coming to glass, we know we're going to drop this glass, it's going to break. I don't even have to tell anybody that, come on, let's look at the physical properties, look at the mechanical properties, analyzing this. No, stupid, stop that nonsense. Don't talk like a big scientist. Even a kid knows that. It's not a big rocket science. If you drop it down, it's going to break. That was the small fear with everybody. Every practicing dentist, oh my God, glass ceramics, if it breaks, I am responsible to answer the patient, give me something strong. So glass had 2 components. One is lucite glass and lithium disilicate glass. Lucite glass is more popularly in the market as IPS Empress. Okay, Ivoclar porcelain system. IPS Empress and IPS Emax. Emax became so popular. It's a patented product, so nobody else could replicate it. That's why it became so very popular worldwide that people tell that world speaks Emax. Got it? So now, but this gives very good aesthetics, but the strength is always was a big criteria for everybody, because the strength, if you look at it, it was now 500 MPa. To be very frank, that is what is the strength of the metal ceramic. Somehow people don't believe that it's, oh my God, can I do a posterior crown? I love to get a posterior crown done with that, but no, people want more stronger. And the other manufacturers captivated on the thought of this and then told that probably we'll do something which is more stronger. That gave birth to zirconia. So zirconia oxide was born, and that came to a strength of 1200 MPa. Everybody told that it's white in color, you can use it. So people started to like zirconia so much because it's strong material, it's not going to break. Now let's look at the history. Lucite glass, I told you Empress, right? Now, Empress is slightly weaker. So maybe if it's a highly aesthetic case, and imagine I have something like this. Imagine this is a tooth, and you saw this lamination, and I put it here. That's all. Sticking. Sorry, not to talk about the girls. The girls put some nail stickers, right? If you're using something like that, then probably just nothing, no adjustments, just for beautification. 1 minute. Okay, sorry about that. Okay. So if you're looking only about beautification, just adding one layer without any extensions, then probably Lucite is a good option. Then putting that together, everything. So, but on the whole, I would suggest the Emax system. So when it comes to laminates, my choice is simple. I don't even have to discuss so much in this material science. It's only Emax. Because it's proven, it's 15 years in the market. I myself have a 12-year, 13-year follow-up. And then though a lot of other companies have come up now, they need a track record to perform on the clinical side. So what do I do by Emax is that it has a CAD/CAM technology and a press technology. It's that this is what is the coping, and then people layer on top of it. This is what is Emax generally. So glass ceramic, beautiful. So this is what we recommend. So please remember, though other companies have lithium disilicate now, we are a little hesitant in advocating them as clinicians and academicians because we don't have enough track record of them. So we will stick on to Emax when thinking about laminates. Please, laminates. There are a lot of reasons which I'm going to tell. One reason is obviously aesthetics. So if it's inlay, no, I would not suggest. Onlay, yes. Laminate, 100% yes. Crown, yes, but staining technique. Bridges, no. So generally, most of my work will revolve around Emax only, except for bridges. That's where I use my zirconium. Coming on to zirconium, it's a story. See, actually, even before zirconium was available, aluminum was there in the market, aluminum oxide. But if I come and tell you that, doc, aluminum oxide, aluminum metal, why do you want to bring me metal? I'm looking at a non-metallic restoration. So everybody, even a kid would know aluminum is a metal. So what to do? They searched and they found out this. You see the atomic number 40, that is zirconium. What? Have a close look. It comes under the category in the periodic table, which everybody has done that in the +2. It's a transitional metal. Now the next question you would ask is, what is a transitional metal? So transitional metals are less reactive. Probably have an iron bar here, and then I put this iron bar outside, then it is tomorrow iron oxide or rust. Zirconium will not happen. So zirconium will get converted to zirconium oxide only by us. So they move zirconium, which is a transition metal, to zirconium oxide and call it a all ceramic restoration. In addition, it can get colored. That's all. It solves the problem. So everybody was happy that zirconium. You still don't believe me? That is a radiograph of a zirconium bridge and a PFM crown. It all looks the same. So metals will definitely be radio opaque. That's exactly what zirconium oxide is. Now, when you look at glass in the radiograph, look at that, how soft it is. This is what is the difference. Unnecessarily, people not knowing what exactly is zirconia, and actually, if you ask me, people are misusing. So you have seen so many times the flame that comes out of when you're trying to trim the, sorry, you see that? So that simply means that diamond burr, hitting diamond can only cause a spark. So it is so tough. Do you want the toughness in the mouth? Definitely, I don't want it. So we have done a lot of work changing crowns. Now look at those two crowns, zirconia, and we change it to glass. Beauty. Beauty comes only with glass. So please remember, more than beauty, there is something else also. It has to stick. Zirconia cannot bond to the tooth structure like how ceramic can bond. This is a non-retentive preparation, and the whole retention is only by the cement. So please remember, you need a good adhesion so that your laminate will stay. So that's why one is aesthetics, other is bondability. So we have a lot of zirconium oxide blocks coming up with colors, multiple things and other things. But please remember, zirconium oxide can only be manufactured by CAD/CAM because it's a metal. Otherwise, you have to melt it and pour it. So what they do in the laboratory is, this is a short video on CAD/CAM actually. So in the laboratory, they would start designing and then they would start the milling process. So first is scanning. Today, most of us are used to the digital scanners, intraoral scanners. So we don't make physical impressions or analog impressions anymore. So these models are almost getting obsolete these days. So direct scanning, and it goes to the laboratory, and then you capture those images if it's a model. Then a three-dimensional reconstruction is done. After that, we do the coping, and that goes for milling. This is exactly what is CAD/CAM. So zirconium is done only by CAD/CAM, nothing else. Got it? Today it's more of a digital world. Everybody talks about digital dentistry, and we have already moved. We do everything, take an impression, digital impression, do our designing, and do our milling. That's all. It's precision to the core. So many times you don't have a physical model, you just have a small crown or laminate in your hand and keep looking at it. Oh my god, if it's going to fit in my patient mouth or not going to fit, that fear will be there. But 99.9% of the time, it's exactly fitting with a beautiful contour, contact, and the occlusal stability. So we don't have to do any adjustment at all, just fix it and lift up. That is what is the advantage of CAD/CAM. So the milling would start. So that's how you see a zirconium blank being milled, and that is exactly right in front of you. So this is very, very soft. I don't know how many of you have seen it in the laboratory. This is very, very soft. So it has to get hardened. The hardening process is called sintering, and sintering not only hardens but shrinks the ceramic. So it shrinks almost 20% of the ceramic, and then it gives you the hardened thing. So there is a volumetric change. If it's not done properly by the laboratory, then the fitting is an issue. Why? Because every company which gives a milling machine also gives a block, also recommends a block. If the dentist wants to buy some cheaper blocks and then fit it into it, and the calculations exactly go mismatching, and then your ultimate fit will not look good. That's why more and more people telling, why is my zirconia crown breaking? Yeah, it's a common fact. Whereas that doesn't happen with glass. Glass, once you mill it, if you're doing a CAD/CAM, you mill it, and then it just strengthens in the same shape. So absolutely no mismatch in the fit at all. So coming to the final question, what all can I fabricate with zirconium? Inlay no, onlay no, laminate no, crown maybe if it's a softer zirconia, bridge yes. But please read the instructions, because every zirconia has its own variations. Mostly, if I was a clinician doing a case with any zirconium, I would make sure that I'm replacing only 2 teeth at a time, not more than that. If it's more than that, if it's a long span bridge, my choice would be PFM, TMLS. That's all. So PFM will still stay. It will not go. Zirconium will be there. Glass will be there. You have to make your choices wisely. So make your choices wisely. Don't get carried away by any material. As a clinician, as an academician, put all the data together. This is what my patient's information. This is what my material, which goes matching the following. That's all. So, but coming on to one conclusion, coming to the end of part 1, if it's a laminate, 99.9% it is only Emax. 0.1% can be Empress. That's all. It's Emax, Emax, and nothing else. So that brings us to the end of 1. Now going on to tooth preparation. Please understand, today at any given platform, if I tell that you cut 1 mm incisal edge, 0.5 mm labial, that is wrong. Today, nobody can give you set standards. Otherwise, I don't have to talk. I will just give you, I have made a small PDF. All of you read this and follow. I can do this and I don't have to spend 1 hour with you people, right? Today, it's more of biologically driven dentistry. You don't have to actually look into tooth reduction guidelines. Success depends not only on the ceramist, but equally or more on the dentist. Your tooth preparation is more biologically driven rather than the mechanical. It's not that taking your burr and grinding the tooth. No, it's those concepts are gone now. Fine. Please understand, tooth preparation guidelines are more biologically driven so that you reduce the biomechanical risks. So it has to beautifully follow the anatomy of the tooth, reducing the biomechanical risk. So the minimum requirements today, I need to call up the lab. We're going to start with case which we already discussed. Now tell me, we're going to select the material. Now tell me the tooth reduction. So that is how we communicate to the lab. And today I cannot tell you, come on, everybody take a screenshot of this, go ahead and do such tooth preparation. Not going to be there. So what am I going to discuss in this segment of tooth preparation is 2 things. How should my margin be? There should be margin be. That's all. How should my margin be? Right? There are a lot of configurations we call. We have heard about shoulder, chamfer, shoulder with bevel, radial shoulder, knife edge. So many things we have done. So what is the answer here? Is that, sorry, what is that we are going to use? Chamfer is for metals. That's all. Forget it. If you're doing a metallic restoration, chamfer. Shoulder is for porcelain fused to metal. We have something called as rounded shoulder. Exactly what you're seeing. On your screen, to your left, you're seeing a chamfer. On to your right, you're seeing a rounded shoulder. Why rounded is that glass, it should not have any internal stress concentrations. So what do? You have to rounded. All internal line angles have to be rounded because glass will get stressed up. So a shoulder getting rounded is having the bulk at the same time giving the less stress concentration. Now what about knife edge? Knife edge is like, I have a case like this, a peg lateral. What should I do? Obviously the choice is a ceramic laminate, but here I just have to add something. Why do I have to do tooth preparation at all? Already the tooth is so small. So I know this is a little advanced level, but I want everybody to know such an option is also available. So I know my technician can do this. So I make an impression and send it to the lab. Look at that. No margin, no tooth preparation. So the edge will be almost knife edge. Got it? So there you are. So this requires little bit of clinical acumen to come to this level. First is I would advise everybody doing ceramic laminates perfectly with margins there. Then you can move to this marginless dentistry wherein your restoration beautifully blend there. Fine. So that is about the margin. Now coming on to the biological bit, which is where do I place the margin? So where do I place the margin is that at the crest, below the crest, or above the crest of the gingiva. So supragingival, subgingival, and at the crest. This is what is respecting the pink aesthetics. So supragingival, at the crest, and subgingival, where do we place the finish lines is that, though some people tell that probably you can go little subgingival, I would strongly suggest only at the crest of the gingiva. Nothing, all my cases which I'm going to, few cases which I'm going to project, everything is at the crest of the gingiva. Nothing is subgingival because anything that goes subgingival might irritate the gingiva, so I don't want to take a chance. And supragingival, where do I give is that when the aesthetic requirements are less, then I do a supragingival. Fine. Now look at this case. Anterior 4 laminates are there. Look at the mirror image. Can you see the margin? Even it's not a big projection, but still you can go close and actually look at it. You see that the gingiva is actually overlapping. So it is actually at the crest after some time. That is what is the beauty of the glass compared to zirconia. It is your gingiva would actually go slightly on top of it. Now look at this, the supragingival. If it's a posterior tooth, why do you have to go at till there? For me, margins is a very, very sensitive area. I want a beautiful, when I'm doing a review, I want to check what is happening in my margin, because that is where all problems can happen. So in a non-aesthetic zone, I would love to do a supragingival. Now, let me explain a little more here. Okay. This case, we started off, we know that the gingival position of the incisors, central incisors, are not very idealistic. So we moved the gingiva up. I did a laser gingivectomy, did ceramic laminates, and I get to see the patient after 3 months, and you see the gingival activity there. No, I'm not happy. We have violated the biological zone in the process of doing laser gingivectomy. So probably when you're planning gingivectomies, please use a PerioPro, go inside, check how much of bone is there, check how much of gingiva is there. See, mistakes, it's not that I'm putting somebody else. I would love to share my mistakes, because that's when people learn. So instead of taking success photographs, I will never miss taking a failure photography at all. Now look at the next case. This was also canine to canine, immediate post-op. Then we see the patient after 3 months. Oh my God. If this is the stage, in 1 year, one of the laminate would pop off. 100%. I can give it in writing today. Why the hell? It's because poor maintenance from the patient. The patients, can you see the plaque accumulation? So it's not to do with our margins or to do anything else. It is the patient maintenance is not very, very good. So these patients should ring a bell in us and create an alarm. So we will put the patient on strict oral hygiene instructions, review the patient every 2 weeks for the next 2 months, and then after 3 months, and then proceed like that. So please make sure that your patients are being recalled, assessed for the long-term success of the procedures we do. Clear? Otherwise, we cannot do predictable success. Now, coming on to margins, essentially all my margins have to be only in enamel, no dentine. If dentine is involved, it is only sorry, just a minute on the box logo. 5 to 6 years, that is all. Fine. So beware, these patients, little risky patients, so much of dentine involved, my success rate is going to drop down, and we could finally somehow get this to this level wherein at least my margins are at the enamel and not at the dentine, though a lot of dentine. Why am I so much stressing enamel? Enamel is that this study was done in 2013 itself by Gallup Gruel, when he beautifully told that enamel preservation is very, very important. He told that if it is not an enamel, it is 10 times more likely to fail. So first thing is, at least I don't want my margins in dentine, and the whole preparation should be in enamel only. Now you understand why I told that today I cannot tell you do 0.8 reduction. You might land in dentine. Every case is different. One might be procline, one might be retrocline. So it completely customized tooth preparation. It cannot be a regular tooth preparation everywhere. I'm going to show you some cases here. Now look at this. This is a multiple diastema. Am I going to do ortho? No, I'm not going to do ortho, because the canines are already there. And it is all perfect. If I do anterior consolidation, canines will move forward, and this is not the right case for that. And what else do I do? The patient is asking for something. Am I going to do composite? No, composite will be too huge. I need to beautifully do a proportioning work here from canine to canine. So the best thing is I'm doing canine to canine ceramics. That's all. But ceramics and diastema. So if you have diastema like this, the maximum allowed is only 2 millimeters. That means if I put a laminate on this tooth, only 1 millimeter can overhang, beyond which it will break. So that case will go in for a crown. So this case was crown based on the suggestions of the laboratory technician. So look at that. Look at the crown preparation. Nothing. You see, it's very, very minimal. You still see the shine of the enamel. Nothing we have done. Look at that. Very, very minimal tooth reductions, and finally we did the crowns. Canine to canine. Now, these are the general pictures what you get to see when you look at ceramic laminates. The maximum allowed is 0.7 mm in the label side. That's all. Infection reductions, if you're doing it, it's 1 mm. Otherwise, forget it. Margins, it depends on what type of margin you're placing. maximum would be 0.6. So maximum 0.6, 0.7 is the criteria where you stay in enamel only, beyond which you drop into dentin. Now coming on to the palatal side, it is very important that you don't go into the red zone. The red zone, the fossa area, is where a lot of stress concentrates. So please don't go into the red zone. So as a rule in incisors, centrals and laterals, we don't do overlapping, because when you do overlapping, there is a tendency of going into the red zone. Only for the canines we do it. All centrals and laterals would have a butt joint like this. Can you see a picture here? It's like, sorry, I've taken a knife and chopped them off. So it's going to be flat like this and not overlapping like that. That overlapping will happen only in the canines and the bicuspids. So in centrals, it is just one flat line like that. Now, one important thing is that it's like a crown preparation only in the label surface. So one important thing here is that proximal subcontact area. So what is that? Is that when you see the patient in the lateral angle, you will get to see the margin if you don't go inside the subcontact area. What is the subcontact area? Is this area what you're seeing, which I marked with a black line. Generally, if we don't prepare that area, below that is the contact zone. So above that is the subcontact area. Now look at that. So you have the contact area, and if you have the subcontact area. So if you don't go into the subcontact area, when the patient turns like that, that margin will be visible. So visible margin is an aesthetic failure. So I don't want to do that. So this is the only technique sensitive which we teach in our hands-on program, is that the burr, like you do the crown preparation only, nothing, you've decided where the margin, the shape of the margin, you have selected the burr, you have done everything. Then what you do is that you go inside, and then without breaking the contact, you come out. Question is that if I break contact, what happens? What? So please don't try to break the contact. This is the most technique portion in preparing the proximal subcontact area. So there you see an ideal tooth preparation, wherein you see all tooth preparation label done with involving the subcontact area. Nothing is there broken the contact, and the incisal edges are flat. Now why I told customize is that, now look at this case. Now the tooth is like this, two central incisors are like this. So actually I don't even have to touch my mesial side, because mesial is already retroclined. Only the thing is proclined is the distal portion. So I need to do more of distal reduction and less of mesial reduction. But again, making sure my distal reduction will not go into the dentine. If the tooth reduction is more, then my choice would be orthodontics and nothing else. So that's exactly what you're seeing in 4 teeth, more of distal reduction, less of mesial reduction. This is why we put the tagline customized preparation. Now you see those customized preparation which would not be there in any of the textbooks. So there is the key. Another thing is that, look at that. Another people always tell is that single centrals, it's better we do 2 centrals because shade matching in a issue. Actually that for the fault from our side, we are not supposed to do 2 central incisors so that it comes beautiful. This patient comes with the complaints of fractured tooth, and also she incidentally wanted to get that proclaimed mesial side get corrected. I told that we'll do a single laminate, and that's exactly my lab also told, we'll do 1 laminate. So now look at this preparation. The mesial side was proclaimed. So we thought that we'll just reduce the mesial side, I will not touch the distal side. So what is the margin? So one half of the tooth will have a rounded shoulder, other half will have a knife edge. So these are the innovations what you do. Now look at that. Can you see the margin disappears in the distal side? So integration of the laboratory is very, very important, because this is the post-op. So whatever the patient wanted was achieved. Look at the lingual side. You cannot even make out which is treated because they all look alike. This is what is the beauty of the glass. So again, to conclude this session, I would tell that key to success is customized preparation. So tooth preparations are customized in laminates, do not follow strict rules at all. So this is the summary of part 1 and part 2 of the lecture. So we are left with the part 3, whereas case discussions, I will not talk too much now. So I'm going to show you cases and wind up with the cementation protocol. Fine, another 15 minutes, we should be done. So preparation, design and material science. So no prep, it can be composites or glass. Minimal prep can again be glass or glass based with fillers. When you're doing traditional preparations, then you talk about oxide base. So this is the final summary of part 1 and part 2. In this, I've been always talking about lab integration. Okay, effective lab communication is the key to success. If you're not able to communicate to the laboratory, then your work cannot stand up to the mark. So now, photography becomes very, very important. How do I communicate? My lab is almost 1,200 kilometers from here. Then I can't send my patient to the laboratory, or I can't go to the laboratory. It's all digital communication. So I put my case in PowerPoint. I tell them this is how. This is not after tooth preparation. This is even before that, case discussion. So we discuss the case with the laboratory, and accordingly we start the treatment planning and give the treatment planning to the patient, and the lab by then would send us mock-ups. So these are wax mock-ups telling us eventually we start from Chennai, we're going to go to Mumbai today. So this is the starting point, this is the ending point. How are we going to travel here is the clinical treatment planning. I'm going to do gingivectomy, am I going to do orthodontics, am I going to do tooth reductions? We are the best person. What is the role? Keeping tooth reductions as minimal as possible. If the tooth reductions are high, then the only way is to do a orthodontics. So they send us guides, everything. We do imaging, send it to the laboratories. And after the mock-up, we done a test drive. I'm going to show you in the next case, you will understand. So we do, and we feel that the mock-up is not, I'm not reaching Bombay, I'm just falling off in Pune. So let's start all over again. So communication to the laboratory is very, very important. The next thing, people talk about shade selection. Please, the only way to communicate to the laboratory is again photography. Though there are many factors that influence the shade selection, value is the most important. So what I do is that I put 2 or 3 tabs. Now today you can do it with your smartphone. Take a picture, convert it to grayscale and send it to the lab. The lab will actually do the shade matching and the shade mapping. So not one shade tab. If you feel A2 is the right shade or A3 is the right shade, one shade darker, one shade brighter. So 3 or 4 or 5, put it and send it to the lab. The lab will make the decision. And also if there are coming across discolorations, if you have discolorations happening, then what you do is that we have an ND shade guide that's from Iowa Club Evident. So they give the actual discoloration guide to the laboratory. ND9 would be very, very dark. ND2 is almost normal. So please try to buy this shade guide, which actually gives good communication to the laboratory. So that brings us to the final part, which is, I hope it's going to be interesting to all of you. Step-by-step protocol to success. And then I project 2 cases of me, how we did that, and a little bit of cementation. Fine, cementation is also very, very important. So as I've been already discussing, treatment planning is very, very important. I should listen to the patient. What do you want? Tell me. It's not that what I want, what I see. If I have a hammer in my hand, every problem becomes a nail. I need to hear to the problem, correlate all the data, then discuss counseling, and then only do the treatment execution. Immediately the patient comes and then I start grinding, I will not sleep that night. I feel I made a major mistake. So let's see a case, the working philosophy. This patient comes to us with the unhappy smile. Obviously she has undergone some ceramic laminate work and she's not happy as it's not good. So she wanted some change and she wanted a little bit to bring it out. If she was asking if ortho is possible or something. And then we have a group. We live in a digital world, so we put everything. I don't have to wait for my orthodontist to come and see the patient. I don't have to wait for my surgeon to come and see the patient. We all discuss the case in the WhatsApp group or in any other platform that you want, in Dropbox, and then discuss and then project it to the patient. So by then the lab is also involved because this is an indirect case. So the lab is also a team partner to us. So we gather all the details and then project it to the patient. The surgeon, the orthodontist opinion, the surgeon's opinion.
Pictures. I can bring your teeth out, yes, but the space which is going to show on the sides, that will not be very aesthetic, it might not look good, and it's very difficult to close that space as well. So braces, not a good idea for you.
So orthodontist told don't want braces. Now let's see what the surgeon is telling. If the orthodontist is moving up with the...
Hi Aparna, I'm Dr. Suresh, I'm an oral surgeon. I've gone through your case completely, but I'm sorry, I don't think I can do much in your case. Even though the orthodontist can do something to bring our teeth forwards, the amount of space what we're going to gain going to be very little. So I don't think we can place implants.
So everybody is giving the opinion, and I'm recording that and showing it to the patient. Patient doesn't have to schedule an appointment. No, the orthodontist is not there today in our office. She's gone somewhere. He's gone somewhere. So we do all the workflow. Fine, we finish all the workflow, and then we project it to the patient. Fine, we do the digital, we do the analog, collect all the data, and one fine day we tell the patient, come on, look at this. If we do this, this is what will happen. If we do this, this is what will happen. All that is projected to the patient, and then we come to a treatment planning. So even that stage, we don't immediately jump into making impressions. We remove all the old laminates first and put her on so-called temporaries. Today, please don't call them temporaries, they are prototype restoration. So now the patient starts communicating. Look at that. I didn't even ask her. I'm able to talk more legibly now. So slowly, the patient start getting inputs, and then finally we have the pre-op and the intra-op. Once the patient gives the green go, doc, I'm happy, then we start the ceramic work. So it's a journey we travel. It's not an overnight magic. Today you come to me, tomorrow, no, you are not my patient. You are not my patient at all. So you have to develop this working philosophy. This working philosophy strictly follow, no compromise. If you start compromising, patient will start bossing over. So don't do that. So once we reach that stage, only then we create, I refine my preparation, I take my impression, I send it to the laboratory, and that's where my lab delivers a smile what the patient wants. Okay. So reaching there, here, probably I may take a train, I may take a bus, I may take a flight. You are the clinical judgment. You're going to make the clinical judgment. So finally, the patient should be really, really happy in all aspects and the outcome of the treatment. Now that is what is happening. That is what is a patient who is.
The smile was very bad earlier. Compared to that, now it's like awesome. It's good always. Now it's much better, and I feel much more confident. Like Munadi, I used to feel very with the old veneers. It used to be very long and very bulky. So other compare now it's like much better, and I feel much more happier about the outcome.
So that is what is the working philosophy. So as I told you, orthodontics or restorative or simple reshaping also. So I'm going to show you some cases like that. Two cases. Case number one, which I already showed you what my orthodontist could do after extraction, and what I do is that nothing. I just spoke to the patient. 3 people, myself, orthodontist, technician. I have been orchestrating the whole work. Orthodontist did his job. What did I do? I made an impression. Communication was only my part here. That's what my ceramist did. So at the end of 6 months, I've not touched the tooth is not seen by the aerotor handpiece at all. Your biomechanical risk is 0 before treatment and after treatment. You have not increased the risk at all. So this is what is treatment planning. Now let's see the other case. So now look at this case. 2 centrals have been, one central is fractured and 2 laterals are going away. So do I do ortho or what do I do? I told you the stability of the stomatognathing system should be the end portion, right? So here, if I do ortho, will I get the same stable stomatognathing system? No, I'm doubtful. Because the molars are beautiful for this 22-year-old young girl, which I don't want to disturb. What am I going to do? Very minimal reductions in laterals and centrals and give laminates. That is more conservative than actually creating a occlusal risk, a functional risk. So I don't want to create a functional risk. I don't mind. So this is an equation. This comes under treatment planning, wherein we put small equations and do gingivectomies, and then finally we do a little bit of preparations and put the patients on prototypes. Now here, the patient is on prototype. It's not on the permanence. And then I project it to the patient, and the patient looks at it.
Yeah, like the length is really nice. And it gives a better smile. Like, I wish like my side is that which one is not open?
Yeah, we pull those things.
Yeah, it's really nice. Wow.
So
You did an amazing job. Oh my god.
So we have to reach there. After that, The patient gives a green signal. Doc, I'm happy, get it done. In the Western world, they get the signature from the patient at this point of time. I make an impression of this, send it to the laboratory just duplicates that and give it to me. So final appointment is happy appointment. It's patient, doc, look at this, look at, no. We have done all the test driving. We have come to this stage, and that is where we are today. Okay, where we started and where we finished. Yes, we know our destiny perfect, and we know we have done the laminates for this patient, but it's not that patient came to me on the first appointment and the second appointment is cemented. It doesn't work that way at all. So it's a working philosophy what you need to follow, and to reach here, it's not, again I repeat, it's not an overnight magic. It's not about learning a procedure, doing it. It's about skillfully making the patient happily smile with the dentistry what you're doing. Fine. So that is the final day of the picture what we made, and then we will finally wind up with the adhesive cementation, because this is a this is a non-retentive preparation which you need to stick it up. So the only thing is that you think about the adhesive cementation with the resin cements. Okay, now there are a lot of resin cements available. Please remember, it should be either a light cure or a dual cure. I'll put it in simple words. So you have the tooth, you have the restoration, in between is the cement. So we all know how to do etching and bonding. Fine. So in the tooth, we etch and bond. That is already in a composite. Now we have the ceramic restoration, which has to be bonded to the tooth structure. So with the luting cement. So what do we do is that the same way how we etched and bonded the tooth, we need to etch and bond the laminate also. So what are the materials today? Glass, oxide, base metal, noble metal. So we are talking only about glass, which requires silane coupling agent. After acid etching, sandblasting is done only for zirconia. So after acid etching, we need to apply the monobond or the silane coupling agent. So silane is what you see here. So the pre-treatment, so how we etched and bonded the tooth, we need to etch and bond the restoration, then put them together. So I etch with hydrofluoric acid and then put the silane coupling agent and put the resin cement together. So we have don't have many primers today. We have just one primer monobond, and that is performing very well. That's again from ivoclavivudin. So we just put that and then stick it onto them. So coming onto the cements, I told you only light cure and dual cure cements are aesthetic cements. So when do I use a light cure cement and when do I use a dual cure cement? It's a big question. See, light cure means only if I take the light and put, it will set. Otherwise, it's going to give you a lot of working time. But the dual cure cement will have a short working time. At the same time, light has to penetrate. Probably you're treating discoloration and the laminate is slightly opaque, light cannot penetrate. So dual cure is your only choice. So the choice is made by you. If light can penetrate, light cure. If light cannot penetrate, then it's dual cure. Fine. So please keep that in mind. Accordingly, make your selections. Lovingly, I would love to select only light cure because it gives me a lot of working time. But the situation has to answer. So this is what is the light cure and the dual cure cement, what you're seeing. So the material choices is very, very important. Cementation, of course, every cement gives you instructions to use, but if possible, just download this app, Cementation Navigation, cns.com. That would give you beautiful guidelines for cementation. You don't have to scratch your, because worldwide cementation is a big issue. So please download this app. This app will tell you what are you doing, a laminate, crown, whatever it is, what material, how much have you prepared, is it vital, is it non-vital, if it's non-vital, if it's discolored, all that data it will be gathering and then giving you a beautiful PDF and a YouTube video which you can follow. So at the end of the day, I hope conveyed the message. It's not about just creating happy smiles, it's creating happy and healthy smiles. It's a teamwork. It's not that you prepare, send the impression to the laboratory and do laminates. Laminate is a part of a procedure. Fine. So I do smile makers with only orthodontics, or sometimes with composites, sometimes with bleaching, sometimes with ceramics. One of the options is ceramic laminate. So what material I use? It's only Emax. Cementation, preparation, everything is customized and not with the protocols what we follow. So thank you so much for listening to this. If there are any questions, if the coordinator is there, I would love to answer them.
Hello, Dr.
Hello.
Rashid, can you? Hello, sir.
Hello, yeah. Hello.
Hello. Sir,
Hello. Yeah.
some.
Yeah,
I
if
think
somebody
maybe.
could read out the questions, I can answer.
Okay. What is absolute contraindication of laminate?
If the tooth is non-vital and if you're not able to bond it, then it's an absolute contraindication. Otherwise, every case you can do. So what do I mean by you cannot bond is that, see, probably somebody is going to construct a building. They will do the soil testing. So what is my soil here? Enamel. If my enamel is not good, if it cannot bond, if I cannot bond onto my enamel, then that becomes an absolute contraindication. So bruxism, all that is gone now, deep bites, all that can be taken care of. But if you're not able to bond and the enamel is not good, then it's an absolute contraindication. Non-vital teeth, generally I don't prefer. If it's freshly non-vital, it's okay. But if it's heavy non-vital for almost 3-4 years, then I would not bond that. So ultimately, if you're not able to bond, then no laminates.
Sir, use of feldspathic for veneers.
Yeah, that's a good option. Unfortunately, not many laboratories do that. See, you saw, right? It is a block which is pressed or milled, but feldspathic is actually layering, just layering. So the strength of it is very, very less. So that's why most of the laboratories don't do it. But like I told you, if I have one sheet to be placed, then feldspathic would be the first choice. But you have to be clinically sound enough to cement this, because if you slightly press it like this, it will break off. That is why people are scared. See, probably I'm writing a book today and only 2 people can understand. It's not going to be a commercial hit. Every clinician should be able to understand. So that's when they hit a aesthetic and a strength level, and that's why Emax got popular. But given a choice, if it's aesthetics, feldspathic would give very good results. And we don't have much labs to do that also.
Okay. Tell something about luminous.
What happened was, people, especially in the Middle East, wanted white teeth. Somehow they are attracted towards white teeth. So they all got fascinated. I have nail stickers. I stick on my nails and something like that. Can you stick on? So manufacturers thought about, we'll just stick on something. No preparations done. Just make an impression. Just stick on to them. They had a separate cement, separate. Probably if it's discolored, they have to use a particular cement like that. And it was all chiclet white. See, it should sell worldwide, right? So it was okay, but imagine you have a teeth like this, they try to stick out, it'll just slightly come outside, which patients will not like. So basically luminous were just sticking with a particular cement specified to that product, which you have to use. So those ceramics, those cements, you stick it onto them, you get whitey teeth. Thanks to luminous, in one way, though they are not practiced in the same way it was introduced, they gave birth to no prep laminate. So today we do no prep with Emax, but the cement is absolutely your choice. You don't have to stick on to a particular cement like we give a kit in luminous. Still some people do it in Middle East.
How do you remove the old laminate?
That's the most toughest thing for me. I definitely need magnification for that, and I would use magnification and diamond burrs to remove them slowly. Mostly I will reduce the water spray also, because it'll zoom go like that. But most of you would not be having an electric handpiece. Now all of you will be forced to get that, because we are not supposed to do any aerosol. Electric handpiece is controlled cutting at a little higher speed than the micromotor. So you know when you're reaching, when you're done with the ceramic and then entering the tooth structure, so that you get to visibly see. So magnification and less water cutting is the only way in which you can remove the previous laminate.
Sir, what about amelogenesis imperfecta?
See, amelogenesis imperfecta is another classical case wherein enamel is not sound. So I'm not going to do laminates. I will do only full crowns if it's amelogenesis imperfecta, definitely not laminates. So please remember, enamel should be sound enough for the bonding, otherwise it's not going to bond.
So one participant asking, any special kit needed?
No, you don't need any special kits. Nothing. You just select, you already must be having etching and bonding for your tooth structure. You just buy one etching and bonding for a ceramic if you're doing a laminate. Most often as beginners, the laboratory itself provides you the cement and they charge, because the kit would somewhere cost around 12,000. If you're doing routinely many cases, it's okay. But today labs, like even Dencare lab gives you, if you ask for cement, they will give you the cement, the etchant and the coupling agent. So you don't have to spend extra if you're in the beginning stage.
One question, please suggest some good cement available for veneers.
I would strongly suggest Variolink Aesthetics from Ivoclavividen, because I've been using that for now 15-16 years now. It's very, very predictable, and since I'm always clubbing it with Emax, same company, I would love to suggest Variolink Aesthetics or Variolink N, LC or DC, light cure or dual cure.
Sir, when you want to lengthen the veneer height, how do you calculate how long you can go?
As I told you, maximum allowed is only 1 millimeter. Like the tooth is here, your ceramic can come outside only 1 millimeter. If it's going beyond that, you'll have to overlap it. Overlap it in the sense, I have to go inside. It will be almost like a 3/4 crown. So please remember, always either in the diastema or the incisal edge, it's only 1 millimeter free hanging ceramic. Beyond which you do, it's going to break.
Would incisal preparation of 1 mm suffice?
More than enough for the current generation ceramics. You don't do more than that, because you land up in the dentine. Sorry?
Cementation of professionals, especially if it is a single tooth.
Cementation, I would use 1 drop of bonding agent. Place it there and a simple flowable composite. That's all. But no etching will be done. 1 drop of bonding agent, little bit of flowable, and then put my temporary there.
What stability of short-term ortho-treated teeth receiving laminates? Will there be a relapse? What is stability of short-term ortho-treated teeth receiving laminates?
Okay, laminates relapse. So the orthodontist will take a call on the retention of it. We generally give splints for all these patients post-ortho. If the orthodontist is looking at a fixed retainer, we also do the fixed retainer. So the retention part of it always comes from the orthodontist words.
Precautions to be taken in occlusal discrepancies.
Precautions is not necessarily an occlusal discrepancy. Every patient is a maintenance. So as I showed you in a picture, it's about how well you brush and maintain is the key. So you'll have to brush well and maintain. And the same instructions, like when you do a composite, the patients are not supposed to bite anything very hard. That is, the maximum allowed is a cut apple, biscuits. All that is allowed. It's not they're going to eat a bone. And we need to find out if there's a bruxer or non-bruxer. So we all give that night guards if the patient is bruxer. So generally in occlusal discrepancies, the occlusal discrepancy has to be corrected. Then we have done laminates also. Absolutely no issues.
Sir, actually,
Hello.
Hello. Sir, actually, our secretary, Dr. Rashid, is the host.
Yeah.
And How he lost his connection.
Okay,
So
okay.
that okay. Someone please, Dr. Harris or Dr. Mohammed, please call Rashid and ask him.
Hi, I'm here. I'm here only.
You Mungal.
No.
Carry on.
I thought of inviting Dr. Mohammed for this session to discuss these doubts and all. It will be better, I think. Dr. Mohammed, hello? Dr. Mohammed, let me make him unmute. But now I am not the host, I think.
Okay.
Okay.
Hello, Dr. Mohan, can you hear?
Yes, sir, I'm there.
I'm Dr. Reep, and I just excellent presentation as always.
Thank you, sir. Thank you.
Well, yeah, my just one query about this peg laterals.
Yes, sir.
So when you prepare, like the extent of the margins and where all should there be any sort of any reduction and any additional modification, that do we really need to reduce, or can we actually utilize the existing enamel as such as a reduced preparation and then go ahead with that? And margins, peg shaped lateral with margins on either side already existing. So should we have a winged type of preparation, or we can just go for a slice there?
Thank you for that question, sir. That is the very, very tricky part in peg laterals. So peg laterals are a classical example for no prep dentistry, wherein you can just add it like that. So what happens is that I take pictures and models or images and send it to the technician. Then he would actually give me a mock preparation if at all required. See, if it is already reduced, you can do no prep dentistry. You just have to make an impression, give it to the lab. The lab will figure out if there are any undercuts. So those areas alone I'll slightly smoothen. Any sharp edges I'll smoothen. And the lab will actually make all the decisions with regard to overlap and other things. So generally from our side, he would suggest or she would suggest how much of undercuts to be smoothened, not reduced, and sharp edges to be smoothened. That is all. Generally, with all the peg laterals, what I've done, it's generally no prep, except the incise edge. If it's very sharp, I'll just round it. Otherwise, everything he takes care. Overlapping to be done, not to be done, everything he does it.
So even the cervical margins need not actually give it.
Cervical margins will be knife edge, as I showed you in the image.
Yeah. And what would be our choice of preparation as far as whether it's a supragingival, if you have a clean teeth on either side? Two questions. One about the preparation margins. And suppose if there is multiple composite restorations on one or two teeth on that, and you want to go for a laminate, is there any difference in the way of preparation, or you would not actually go for a laminate in a tooth where there's already multiple composite restoration?
Yes, sir. The first question is that it's always at the crest of the gingiva. As I told you, I will never go subgingival. If there are multiple composite restorations, I would not do a laminate. I will do a full crown for that, because the margin should never rest on a composite. It should always rest on a sound tooth structure. So if it's involving too much of grinding of tooth structure, it's better I incorporate the whole composite into my preparation and do a full crown to the patient rather than doing a laminate for the patient, because the margin is where very, very technique sensitive. The margin is where the failures start.
Okay. And do you always do a mock-up and show the patient how the laminate is going to be before the or because there are instances where in which our concept or the laboratory person's concept would be different, and they would give us a veneer, and finally the patient might say, no, this is what I wanted. So do you always actually make it a point to do a wax up or a model and then show the patient this is how it's going to be, are you okay with it, and then finalize the plan and then give that instruction to the lab, or you always rely upon the laboratory technician's ability to give a natural anatomy?
Actually, it is always the mock-up. Mock-up comes to us and then we put it on the patient's mouth and then show it to them.
Test drive.
Test drive. We don't actually show the models and tell them this is how it will look. When you want to buy a car, you cannot sit down like this and the sales officer cannot show you a toy car and tell that this is how your car is going to look. You want to actually see how the car, and you want to sit down and see. It's human psychology. The patients wants to see on them how it will look, right? So even when you go to buy a apparel store, you wear the dress and see if it's suiting you or not suiting you, right? So I put the patient on so-called temporaries or prototypes, make them feel how they look good. And if they are looking good, I will make an impression of that and send it to the lab and tell them, just follow this and do. You don't do your own. So that is the working philosophy for us.
So all your preoperative indexes you make in putty, or will alginate also will be good enough just to take a preoperative putty and fabricate a temporary later?
Yeah, alginate is more than enough. Alginate is more than enough. You don't have to do a putty.
I can see so many queries in the chat list. If
so that is Dr. Epan Thomas. He is Professor HOD Oral Surgery.
Oh my God.
No, because I've been the organizing chairman of that IDA Kerala State Conference. So I was there. You were one of the faculties there for the.
Thank you. Yeah.
Sir, one more question. Yeah, basic burr kits. Any tooth preparation kits? Somebody's asked for a basic tooth kit.
Yeah.
Preparation kit.
Preparation kit, I always prefer Identa burrs. They are from Italy. They have all these shapes, the reduction preparation, and you can ask for a rounded shoulder burr. So it's a tapering tapering burr which has a round end. So round end tapering should be the best burr for you. So for us here, Vijay Dental supplies that, and Identa burrs, they have it for them. So I prefer that, and they also have a finishing burr in the same shape, which is very, very important. So basically it's only 3 burrs for me, nothing more. Depth reduction burrs very, very rarely, and then the reduction burrs with a tapering round and a tapering round finishing burr, the blue ring and the red ring burr.
Things to be taken care. Sir, carry on, sir. Deepan, sir.
No, my question is, quite a few cases I've come across with this post-operative sensitivity after this so-called, that's probably because of the extension into the dentin, I believe. So how can you manage once you have cemented the case and then the patient is coming with post-operative sensitivity? Then how will you do that? That's one question. My second question would be, when you do again, confusion part many times, when you do 4 veneers in the anteriors, when you place it with such a small thin shell, many a time little bit of orientation problems do occur. So how is it possible that they can perfectly place the enamel, the so-called shell, in the right location, how it was intended to be and prepared by the lab? Because manually, when you try to place all 4 together, something or the other error happens. So what is the technique for that, and something can you let us know?
So the first question, it was on sensitivity. If happens, we try to use some desensitizing mouthwashes for a period of time. If it's not working out for within 2 weeks, then you have to remove the laminate. No other choice other than removing the laminate and doing it all over again. But generally, it will not come. That means something dentin has happened. Then coming on to how to actually evenly place it is that once it's reached from the laboratory, I take it in the model and fit it and see. There will be one particular angle in which all 4 would seat it. I would memorize it. When the patient comes, I will at least 2-3 times fit it and see which goes in first and which goes in first. So I'll keep memorizing it, and then when I before, it's not that I have the cement here and trying to stick it out. That's not going to happen. So I just try to fit it 2-3 times. I do it. It's there right in front of me. So after all the procedure is over, I carry it in the same way. It's like you go in one way and then you start rotating, right? The same way. That is the only key for this. But if you're still not able to do it, that means something wrong with the placement. So you will have to check individually if it's fitting. If it's individually fitting and altogether fitting, that means the problem is the contact area and not in the actual fit of the laminate. So slightly you can alter the contacts with your diamond burr and then try to fit it in. Even though it's still not fitting, then please send it back to the lab and get it altered.
Yeah. One more doubt regarding that.
Yes,
now
sir.
we have checked the fit of that laminate on the cast, which is perfectly fitting. Now you have tried in the patient. I'm talking about 4 laminates, 90 laminates together. Now you have tried in the patient's mouth also is perfectly adapting and things like that. Now your concern is at the time of cementing whether you can go wrong this way, that way. Now suppose if I, after trying in the patient's mouth, and if I keep the laminates on the model, and with that, if I take a putty bite with that thing, so and then later if I place these so-called laminates in the, will it help, or will it,
No,
there's an error
not
chance?
at all, not at all. Please don't do that. There are 90% of chances your ceramic laminates will break.
Okay,
Don't do that. Don't do that.
Fine. So just memorizing and trying to remind
That's all.
process.
That is the only key. That is the only key.
You place it all together, mix it all, you finish one after the other setting, and then go for the other one.
I do it like this. I do 2 centrals together always. Then lateral canine, or finish one lateral and go to the next lateral.
So my personal question, fremitus and checking for fremitus.
The occlusal analysis always is done even before we start anything. So will I check fremitus for every patient? Not necessary. If the patient is young, healthy, having a stable stomatognathing system, I will not even think about it. Only thing is that is before treatment. After treatment, I should not get an occlusal problem. So there are 2 factors. Either the patient comes beautiful to you and goes beautifully out, comes beautiful and goes with a beautiful smile, but with an unhealthy TMJ. You have initiated a failure process. So whatever happens, I'm not bothered even if my patient is not going with a happy smile, but I want a happy TMJ. So every work happens only in a functional articulation. Everything happens there. And we do a lot of test driving. My test driving sometimes even runs for 3 months. Patient by then, we already judge. If something is going wrong, we immediately check all the occlusal concepts again. When would it happen? Somebody already asked me if I'm going to increase the length, the envelope of function would change. If I'm bringing inside, I'm constricting. So those cases, immediately red light comes. If it's all sound, you're just putting on something onto the tooth, then I'm not good at that.
So Dr. Aisha Husna is asking things to be taken care while doing midline diastema closure with very bulky intradental papilla.
So again, the WhatsApp would give you a clean picture how much of papilla should be handled, and then immediately you take a consult with your periodontist to make sure a radiograph is done, and then how effectively that papilla can be managed. If it's a too thick papilla, it's better only the periodontist does, and I will not interfere with the laser. They would do bone reductions as and when it is required, and then do the gingival correction. After the gingival correction, the minimum waiting period for me would be 2 weeks. I allow the gingiva to heal, then do a trial, and then go ahead with the final preparations and the impression making.
One more question regarding diastema closure and the finish line. Bijoy Das.
Yeah. So in a diastema closure, the interproximal, see, centrals are not flat like that. Got it? It's like this. Yes? So all teeth are not bricks. Flat. So how will the mesial margin be, convex or concave? Convex. So if it is convex, there is an undercut. So when you're doing, all you have to do is that take your burr and just bring it inside. So what happens? Your mesial margin of your 2 centrals become straight and not convex. I'm talking about in less than a millimeter. So I just take a burr and then run it inside so that it becomes like this without any undercuts. Other than that, all preparation remains the same.
Dr. Mohammad Iqbal, in case of peg-shaped laterals, unbonded area, will it be more comparatively increase the risk of failure?
Not at all. Not at all. Not at all. It is the same. In fact, it's bonded. We call them bonded restoration, so not to worry about that at all.
So Vinuta is there. She's asked for single tooth discoloration management with veneers.
First is that, see, the more and more opaque you put, the more and more aesthetics comes down. So all discoloration, let it be internal or external, I would love to reduce the discoloration by the process of bleaching. Generally, single tooth discoloration are hypoplastic areas, fluorosis cases, only in that. So I would try to do some bleaching and finish up that case with composite rather than pushing the case for ceramics. If at all I'm doing ceramics, all bleaching, complete discoloration taken care, and then do. Worse discoloration comes only in the form of non-vital tooth root canal treated. I do a non-vital bleaching, and that case doesn't go in for a laminate. That case goes for a crown. Doing a crown is much easier, and then actually doing a laminate.
So
Vijay Das is asked. Carry on.
In case of, say, the so-called condition where you said in fluorosis, where in which you do the bleaching or whatever it is, now you go in for a preparation, and then is there any difference in the etching time required for cases where there is fluorosis than the regular preparation?
Yes, sir. They recommended little more longer etching time. Probably 30 seconds if you recommend for enamel these days. Probably I'll move to 50 seconds.
Okay. And how do you get that shade right now when you have a different shades in the, suppose central lateral, and this called the fluorosis or whatever reasons, there's different shades. And now what shade should be your kept in mind? Is something lighter than the cananes on either side, or is it something uniform? How do you do that shade part?
Actually, shade central should be the brightest. Laterals will be slightly richer in chroma. Canines will be slightly more richer in chroma. So the shade bright, it moves dull as you go forward. Same way, at the cervical region, it will be slightly dark. As you come down, the translucency comes. So generally, the lab will take care of it. You don't have to break your head. The minute you communicate to the laboratory with photographs, everything is done.
Okay. And what shade do you recommend, sir? 3D pen? The 3D pen is
No.
the regular classical?
3D is not recommended. Any shade guide, what your lab tells, use the same shade guide.
Okay.
You cannot have one shade guide and the lab cannot have a different shade guide. It's
That's
a miscommunication.
Sir, what stability for a short-term ortho treatment treated receives laminates? Will there be any relapse?
Yeah, that's what that call my orthodontist makes. I already answered that. We all prefer a SX4 retainer, or if it's doing for a like a splint, if it's going for permanent retention, my orthodontist would do a permanent retention because it's going to be in the palatal center.
I think we have covered almost all the.
Wow, that's great. Nice to have so many questions. That means people were attentive.
Yeah.
Actually, questions are more when it's a webinar more than when I stand on a stage. I'm happy that way.
Yeah.
All the webinars have been answering more questions than the time. Actually, it's almost last webinar with 40 minutes, only questions, 1 hour lecture. So it's nice.
Mono, any more questions?
One more question is there now. From Dr. Rashid, can we manage discoloration of cervical region with veneer?
The same rules are, if you could do bleaching and then take away, then it's okay. Otherwise, we have to think about some other options actually. So bleaching is a choice actually. You do bleaching and then you decide if it can be managed or cannot be managed.
So one more question is there. Can you show a midline diastema preparation photograph?
Just give me
that is from our CD. That is from our CD chairman, Nurul Islam. So you have to answer that.
I'll just check it out.
Yeah.
After that, could you please throw some light on this electric handpiece, what you're talking about, which is the need of the hour now?
Yeah, electric handpieces are like our micromotor, but they are more controlled. It's between air rotor and micromotor. It's
So the
like,
one with W and H, what they
yeah,
have?
WNH, yeah, exactly.
Yeah.
So we have to check. I think even Confident supplies us that. So
No, W and H come with a water jet as well as internal irrigation.
no.
Do we need to stop it now?
No, that is a different one. We need to stop it now. Actually,
Yeah.
we need to stop that. We cannot use them now because they are more controlled. These handpieces are
Yeah.
slightly expensive and more controlled actually.
65.
So they are a hybrid of air rotor and micromotor handpiece actually. So is there any other question? Yeah.
Somebody has asked, when is your hands-on course?
I don't know.
Smita. I think Smita is from Singapore. She's from Singapore. She's
I
asked
don't
for
know.
the next.
I don't know, frankly, because we were scheduled for the whole schedule is now collapsed. So I don't know what we are with us doing programs. So I have absolutely no clue when we are going to get all this right.
So Emax, do you cement with any other brand of cements other than Veriolink or something?
No, I've not done that.
Ivoclar to Ivoclar. That's it.
Yeah, I prefer that. That is why I thought, okay, it's better to use the same thing.
So YouTube channels any so that we can subscribe and we can learn more and more from you, sir.
Sir?
Any YouTube channels so that
No,
we
sir,
can.
I've not done that at all. Actually,
should do that because you share a lot of information. Like encyclopedias like you actually should be sharing more and more.
No,
and
don't
more
call about me. No. I have a long way to go. I've shared whatever.
So actually it's a testimony. He himself is a encyclopedia for us. Our Condoti IDA. Epan sir is a encyclopedia. He's taken 2-3 webinars and live session in our newly formed branch.
That's good. Nice to hear. I can see from the questions.
Yeah. No, he's not asking for himself, sir. He's asking for the entire.
I know that. I can figure out.
100 of us.
I can figure out from there. Okay, now I'm going to project the picture.
He's like a godfather.
It's a latest branch as far as Kerala state is concerned, and they've come up with so much of innovative ideas and projects you won't believe. Anyway, we won't share that now. We'll share you the link later. Very good branch, very enthusiastic people, bunch of people. Good for idea and good for the people of joined.
Thank you, sir.
Thank you, sir.
Thank you, Epan sir.
Welcome.
Big testimony, sir.
Yeah, keep going. See, enthusiasm is usually always in the beginning. To sustain that is a big challenge, so you should do that.
They will do it, sir. All young people. So that is what you're seeing here is that.
This is for Noor, that midline diastema.
Midline diastema case. I don't know how much projected on a big screen I could show you. That is what. You don't go hug like that. You just create like that. Okay. That is all for a midline diastema. And that's exactly. It's a picture from Gallup-Grewal textbook. That's exactly what you do. Fine. And that's exactly.
Okay.
Hello, Dr. Noorul Islam.
Yeah.
Are you there?
Hello. Yes.
Shall we wind up? Okay. Over to Noorul Islam, CD chairman of Condoti branch for the vote of thanks. I think.
Good afternoon, all.
Yeah.
Good afternoon, sir.
Good afternoon.
On behalf of IDEA Condoti, I, Dr. Noorul Islam, CD chairman of Condoti, use this opportunity to thankful Dr. Mohan sir for a wonderful session for us. Thank you, sir, again.
Thank you.
And Dr. Muhammad to bringing him to IDEA Condoti for a wonderful session for us. And also all team and all participants. Thank you everyone for a wonderful session.
Thank you,
sir.
Thank you so much.
Okay.
Thank you.
Thank you, Dr. Mohan, and thank you,
Thank
Dr.
you.
Mohan.
Thank you all. Thank you all.
Epan sir, thank you. Epan sir, thank you.
Welcome.
We will be again with
Yeah.
so many innovative CDs and all.
Yes. Please
More
continue and
webinars.
please contribute to all the members.
Okay, thank you,
See
sir.
all grow. Thank you. Bye bye.
Thank you, Mohan sir. Nice to meet you and very nice. Thank you. The Zoom meeting is urgent. Thank you.